get started. I'm going to start by asking everyone to please mute their phones. We have a lot of people on the phone, and we don't want to have any difficulty in hearing the presentation. Because of the number of folks on the phone, that there will be a lot of questions, I'm going to ask you to email any questions to me at clean, obviously, and then I will bring those forward to the group after Dr. Fangman's presentation. But with that, let me take just 2 seconds to introduce Dr. Fangman, who will be our speaker today. He is an associate professor of medicine in the Division of Infectious Disease and senior medical director of ambulatory medicine, or MCP. His principal clinical interest is in the care of high-risk patient populations with HIV infections. And we are very fortunate that this morning he is able and willing to speak with us about COVID-19. So with that, Dr. Fangman, thank you.
Thanks, Dr. Lean, and thanks for the opportunity. Just from a sound check perspective, any concerns about hearing me? And I want to, first of all, say thank you for the opportunity to be here. You guys are really, really important, and in many ways, you along with our nursing staff and our critical care colleagues and our respiratory therapists are at the point of the spear. And so I've just been deeply impressed over the last 3 to 4 weeks to see how you as a department and your department leadership has responded to this unprecedented challenge of COVID-19. So I want to thank you all personally for managing all the uncertainty and walking towards the problem, not walking away. It's just been deeply, deeply impressive, so thank you all. We've been trying to, a group of us in infectious disease, to put together a dynamic slide deck that gives people a basic foundation in COVID-19. And the first thing I do in any of these talks, which I've now done to 5 or 6 departments, is put this disclaimer up. It's an amazing time in the world for many reasons, but in terms of the change in the evidence and information that is being accumulated about how to manage this disease, it's very important to understand that what we're seeing today, what we know today, and some of what I probably will say today will be proven to be inadequate or inaccurate over time. So consider this a snapshot in time, not the definitive answer moving forward. So I'm gonna run through this sort of basic outline, talking about the historical epidemiology of this and related coronavirus transmission events, talk a little bit about the virology of this specific pathogen, talk about the clinical features, focus on special populations. I know you guys are very, very aware of and keenly interested in the PPE issue, and I'll talk a little bit about that. So really talk at the end about some mitigation strategies and some ways that we will long-term control this, and then give you some resources on where you can learn more. So we're all aware that this epidemic began in a distinct market in the city of Wuhan in China, a city that's roughly the size of Chicago. And like previous events when an animal virus jumps over into human populations, there is an initial phase of the epidemic that involves transmission in a defined geographic area. But starting in January, early January, Chinese public health officials started to see evidence of cases that were not linked to that environment. So in early January, they saw the typical epidemiologic curve, an infection that is spreading beyond an environmental source of that infection. So in January, they saw a rapid increase, which we're experiencing right now, in patients presenting with unexplained respiratory failure that subsequently was found to be related to this novel coronavirus, which is now called SARS-CoV-2. And one of the things that this slide illustrates is the rapidity of public health response in China and the rapidity of the scientific investigation of this disease, which was very, very impressive. in China, and which holds a lot of lessons for us as a country, and we're thinking about how to respond. You know, in particular, some of the decisions that were made around closing down the city of Wuhan, especially as it relates to the Lunar New Year celebration, will end up being very, very important in terms of the overall transmission dynamics of this infection in both China and globally. So with pandemic rescue, is there anything I'm doing to create that sound? Does anybody know?
Good morning. I'm trying to get a WebEx. It's not working.
I think it would be helpful for everybody to mute their phones that's listening.
So this was the description of a typical epidemiologic curve for, let's say, viral infection taking off. And you can see there's a lag between, as there will be in our environment, the lag between symptom onset and disease reporting. And that's what this illustrates. So right now in our community, and I got a report at 6 this morning, that our testing positivity rate in our community sites is higher than our hospital sites. And that's what you see in this early phase of things. Before people get very, very sick, there's transmission out into the community, and we'll talk about the trajectory of COVID-19 disease and why a slide like this is illustrative. So you guys are all probably aware of this really fantastic site that Johns Hopkins stood up very quickly at the end of February, which has been mapping the diagnosed cases of COVID-19. And I think you probably all saw yesterday we became the country with the most confirmed cases in the world of COVID-19 disease. But this is a very powerful visual that you can use to track, and you can kind of up and down. And I point out things that probably make it almost inevitable that this was going to happen once it was in China. Like the lack of tests in Africa and the lack of diagnosis in Africa. As many people probably know, China has been heavily investing in Africa for a very long time, and the lack of public health resources and testing capability in Africa probably is why we're not seeing cases reported there. It was very likely that Chinese workers going back and forth from December onward into Africa would have ended up spreading this. But, you know, in a year or two, we'll know the exact transmission dynamics of how this moved globally. But this is a site that I look at daily just to understand where countries like Africa or continents like Africa and countries like India are experiencing this, and in countries like Russia, where you can see undoubtedly there's more cases in Russia, but the countries with limited public health infrastructures are oftentimes ones that are not represented in an image like this. So this is an image that I like from the Financial Times. It shows the differences in the epidemic in Asian countries versus Western countries. And you can see all of the Western countries. Italy and Spain are the two big ones in Europe right now, but we're following a curve that's very similar to them and distinct from the curves in Japan and areas like Hong Kong and Singapore, and then importantly the curve that Korea subsequently followed based on their both testing strategies and public health mitigation strategies, which are distinct from ours. So as everybody knows, as of March 11th, we are officially in a global pandemic of COVID-19, which is defined by sustained transmission in multiple geographic regions of a disease. And we're experiencing globally that rapid uptake phase that I've shown you graphically in China before. The Times, the New York Times, this was yesterday's New York Times image of transmission in the United States. And what's happening right now everywhere is testing capacity is coming online, and you'll see a surge of diagnoses coming at us from around the country. There is some heartening data in here. The Midwest is ramping up quickly. We're becoming a relative hotspot, not quite New York, but states like Florida were under testing. You'll see Florida look like New York in short order. But I would point out, that those of you that have been looking at this map before, the West Coast has not grown the same way in terms of positive test results, and Seattle in particular, they've not yet peaked, but they are not growing in the way that the epidemic is growing in New York. So there are some data in here that will give us hope about community mitigation strategies if we monitor these things over time. So these are the Wisconsin data. Wisconsin doesn't present the data as accurately or as visually appealingly as other areas. This was as of yesterday afternoon. We had 347 confirmed COVID-19 cases and 5 deaths. I'm sure that number is quite a bit higher when I look at it this morning. But one of the things to think about when you're looking at a map like this is testing capacity, and diagnoses in Milwaukee are not necessarily because the disease is much worse, or we don't know yet if it's much worse, but we have unusual testing capacity in Milwaukee relative to other parts of the state, including as recently as last week, Madison, where they did not nearly have the in-house capacity to do testing that we do at greater MCW. So let me tell you a little bit about coronaviruses as a general class. It's likely that we've all had the first 4 coronaviruses listed here. There are very common causes in winter months of upper respiratory tract infections. Up to 30% of non-influenza seasonal respiratory viruses are caused by coronaviruses. And these have been a source of investigation for a long time as a potential quote-unquote cure for the common cold. So people have looked for coronavirus vaccines and have looked for treatments for a long time, because as you can imagine, if you could quote-unquote cure the common cold, there would be a public health value to it and also a lot of money to be made from it. But to date, none of those have been vaccinated against or effectively treated with therapeutics. And I mentioned that as a prequel to what we're going to talk about, which is these highly pathogenic animal-to-human transmission events, which have now occurred 3 times that we've recognized. The first being SARS-CoV-1, which was an illness that began in China in the early 2000s, 2001, 2002, and some say it appears to have died out. The ongoing camel-to-human transmission event of a coronavirus that we've now called Middle East Respiratory Syndrome, or MERS coronavirus, and now the current SARS-CoV-2, which is the virus that causes COVID-19 disease. The virology I won't get into in any detail, but the spike protein that's on this image here is the key attachment protein that the virus uses to attach to ACE2 receptors in various tissues and to be incorporated into the host genome. It is an RNA virus, and it uses RNA polymerases and other sort of common RNA enzymes to replicate in the host. So the specifics of the animal-to-human transmission for SARS-CoV-2 have yet to be fully defined, but it's very likely, given the homology between the SARS-CoV-1 and CoV-2 and the geographic relevance of this second transmission event, that it appears that a bat coronavirus is what happened, and this is definitely what happened in the first coronavirus outbreak, SARS-CoV-1. Bat, and then to an intermediate mammal, a civet in this case, and these marketplaces where there's high density of human-animal interaction is where these transmission events are thought to occur. And then this is why coronaviruses in particular are spread now, because once that transmission event happens, it's thought that healthcare environments become a critical driver of transmission, because a sick person from an animal-transmitted event gets taken to a hospital unrecognized and then transmits to the healthcare workers, who subsequently bring it out to the community. And now the global pandemic is fueled by the global commerce and global travel that is so much more prevalent than it was 30, 40 years ago. So this connection between an animal-to-human environmental transmission event amplified by healthcare workers, and we'll talk about the specifics of why SARS-CoV-2 is such a problem in transmission, and then once it gets into the community, it's off to the races, as we're seeing. So the critical epidemiologic consideration with pandemics is what we call the R-naught value, which is the estimated number of people from an index infection that will subsequently be infected by that person. And the most transmissible virus that we have out there is measles, and it has an R-naught of 16. The typical annual seasonal flu has an R-naught of between 1 and 1.3. And the 1 is important because if you have an R-naught that drops below 1, the epidemic will die out. If it's above 1, it will expand. And so as people become immune, the R-naught will drop as the susceptible hosts drop. But at the beginning, the transmission events are driven by when nobody's immune to something, the number of infections in a population that will be susceptible to that infection. And SARS-CoV-2 is thought to be have an R-naught between 2 and 3. It is not as easily transmissible as its cousins, SARS-CoV-1 and MERS, but I'll talk to you a little bit about why they're different and why we have to worry more about SARS-CoV-2 and COVID-19 disease than we do SARS and or MERS, even though in especially the hospital setting, those are more transmissible pathogens. So some virologic insights that are coming out of China are really, really important for us to think about this. So viral shedding is quite clearly potentially present in patients for a day or two before they present to care. So that is going to be one of the real difficult things about this virus. And there's also early peak viremia. So you come in shedding, not knowing you have even the infection because you're asymptomatic. You present with symptoms, and you're at your peak viremia. So that is a difficult combination from a structural perspective to manage. There are other sites of replication. I didn't mention this, but coronaviruses are present in many animal types, and they're a common source of veterinary infections, especially in things like pigs and some chickens. And they oftentimes will, when they go through a population, will devastate them with GI illness more than respiratory illness. And so the stool is a common reservoir for some coronaviruses, especially in animals. And we can see virus in the stool, but there's been no evidence that fecal-oral transmission plays a role. This is all about fomites and direct droplet spread of the virus. And then the definitive data is yet to be out there. But viral shedding, as measured by PCR, definitely occurs for a longer period of time, although it appears that replication-competent transmission of live virus in terms of viral culture positivity drops off dramatically around day 7. Obviously, we have yet to know whether that's the case for special populations like immunocompromised patient populations. So it's too early to be definitive, but PCR positivity extends for a longer period. So far, people in typical hosts have not seen virus transmissible culture positive much beyond a week. So this is some of the data, and there's more and more of this all the time, showing the peak early viremia and then drops in viral swabs in both nasal swabs, nasopharyngeal swabs, and oropharyngeal swabs over time. This is just a little pathophysiology. The ACE2 receptors I've mentioned already in respiratory epithelial cells is thought to be the principal source of the respiratory complications. But when you're thinking about the disease spectrum, these are the tissues that have those ACE2 receptors, and so important. I think you've all been aware of not just the respiratory but the cardiac complications. We're seeing more and more of these funny little renal complications related to it. So these ACE2 receptors are found in multiple tissue types over time, and they'll be important as we think about unusual presentations. The ACE2 receptor has differential receptor density because it's based on X chromosomes, And there's been an observed clinical difference between the impact of SARS-CoV-2 on men and women, and it's too early to be definitive about something like that, but there may be something there as to why ACE receptors may protect women relative to men. So in China, when they first began to describe this, they recognized 3 distinct populations. And when we think about the Chinese experience, remember, they're mostly reporting on people who were symptomatic enough to be connected to the healthcare system. But they describe them in 3 cohorts: mild disease, severe disease, and critical disease. And we'll talk about those in a second. But this is the symptomatology that people presented with: fever, dry cough, fatigue. More and more we're seeing myalgias and sore throat as sort of prodromal symptoms, but obviously very nonspecific, and unfortunately when it's coming up during a respiratory viral season like it did in China and like it still is here, very difficult to distinguish from other respiratory viral infections. So this was the experience on over 1,000 hospitalized patients that the Chinese reported on in the New England Journal late last month. Fever will be prevalent during the course of a hospitalization, but it's very important to recognize that 44% of the time in their experience, fever was not present on admission. So the absence of fever does not give you any confidence in saying somebody with respiratory symptoms or even other nonspecific symptoms who's sick enough to be in the hospital does not have SARS-CoV-2. There is a typical incubation period. If I get exposed, I will worry for the first 7 days. I will particularly worry about between day 4 and day 7, and then I'll still worry till 14 days out. But the typical normal immune host will become symptomatic at typically day 5 or 6 after exposure. There are some lab findings which people are seeing that can be helpful in sorting out other causes of respiratory tract infections from SARS-CoV-2. And those include relative lymphopenia, elevation of inflammatory markers, low procalcitonin, LDH elevations, and then in severe disease, both acute kidney injury and transaminitis. The X-ray findings, I think you guys are probably familiar with now. They're typical viral pneumonia patterns. And if you're doing CT scans, they tend to be peripheral findings, not central findings. So ground glass opacities in multiple segments of the lungs that tend to be peripherally oriented. But a normal chest X-ray is not something that you can rely on, especially early in the course of disease or in milder disease. And one thing I would mention in the SARS epidemic in the early 2000s and MERS still, radiology sites are drivers of infections in hospitals because people transporting down unrecognized SARS-CoV-2 patients or SARS patients were clearly risk factors for getting the staff in those facilities infected and then subsequently extending it from there. So one of the things about radiology in this disease is we need to be very mindful of the need and what we're going to do differently with an imaging finding before exposing the staff to the risk of transmission events there. There are some negative findings in radiology that are helpful, not typically associated with pleural effusion. So when you're seeing somebody with heart failure, the presence of pleural effusions is not typically something you see with the radiology in this disease. Here are some typical early findings. So there's nonspecific ground glass and a relatively normal-looking chest X-ray, followed by more dense consolidative disease as the disease progresses. So the spectrum of illness sort of writ large, I've mentioned the incubation period, but the Chinese estimates, and this is yet to be proven, the Chinese are distinct in lots of different ways from the Italians, from the Finns, from the Argentinians. We'll have to see how this sort of specific plays out, but in the Chinese experience, they said about 14% develop severe disease, 5% will need ICU level care, 2% will need mechanical ventilation, and the case fatality rate in the Chinese experience was higher, but probably influenced by the fact that they don't have as much data on the total number of people in a population that are infected. But we're saying between 1% and 3% at this point. The complications are listed here: AKI, cardiac dysfunction, malignant arrhythmias, cardiovascular collapse are really bad signs of this. The ARDS it will be more manageable than the multi-organ system failure aspects of this. There are some risk factors, obviously age, medical comorbidities, which I'll talk about more, higher selfish score, D-dimer elevations. People are observing D-dimer elevations as a marker as people progress in the disease for likely critical disease moving forward. And then I like to say the one really great thing about this disease is the fact that our children seem to be relatively spared of the effects of this. And I would remind people of the historical precedent of the influenza pandemic of 1919, obviously a different virus, but that virus preferentially took out young, otherwise healthy people. So there is some relative silver lining. So the phases of the illness are really, I just provide some general explanation. So that the original, when you present, oftentimes have a nonspecific lower respiratory tract infection, oftentimes associated with malaise and poor PO intake. The other sort of symptoms are very nonspecific, and you can see how this is very difficult when we have testing limitations to understand how to case find in that setting. But patients that are going to become more severely affected will develop a smoldering hypoxemia, and it's described that people feel less dyspneic than their SaO2 should have them feel. And that's something to pay attention to, that they can be tachypnic and less dyspneic than their O2 sats would suggest. But then a population of them will go on to developing increased oxygen requirements and develop fairly abruptly increased work of breathing, subjective dyspnea, and more air hunger type symptomatology, which is followed in a significant proportion of people to fairly dramatic respiratory collapse. And one of the things that people are recognizing, and this is why you guys are so important, is early controlled intubation is felt to be a very critical part of effective management of people with severe and critical disease. And so doing that in a way that you know better than I, but true rapid sequence intubation, best operator, is definitely what people are describing as really, really important. There is a significant problem with secretions in this disease, and the airway issues that are associated with that. They really have difficulty mobilizing secretions, and that is a prominent feature of the disease. And then this CRP and D-dimer elevation is more and more being observed in association with the respiratory collapse phase. One of the things about this that's important, I'm on the inpatient ID consult right now, and this normal white blood cell count versus elevated white blood cell count is actually something that I think will prove useful in understanding whether somebody has something else or somebody has a co-infection or bacterial superinfection, because it's not common for, even in the severe phases of the disease, for people to have a prominent leukocytosis. And then beyond the respiratory collapse, the risk factors for death associated with this are the development of acute kidney injury, hepatitis, and most importantly, myocarditis and cardiomyopathy, but also there's more and more description of people becoming encephalopathic. And I wonder a little bit about whether there's some neurotropism like there is with some of the animal coronaviruses. So this is going to be our big problem. How much mild asymptomatic disease is there out there? And many of us fear that there's a lot of it, and that will be the driver of how much severe and fatal disease we end up experiencing. So this is an unknown, but this is where the mitigation strategies start to come in. If you can keep people from engaging in contact with each other with a disease that has a asymptomatic viremic phase and may have a prominent infected but relatively mildly affected population, this will be critical in controlling and managing the epidemic as it unfolds. You've all heard about the testing problems we've had in this country. I said earlier that testing is ramping up substantially, and we're, again, extraordinarily lucky to have one of the best molecular diagnostic microbiology groups, in my opinion, in the country. But you can see the proportions The real number here is the test per 100,000 or test per million people. And when these data were produced a week and a half ago, you could see our testing rate, we will soon have done more tests than they've done in China. But the real number is the test per million people. And that's where we've lagged behind. We don't know. We're flying relatively blind in terms of testing in our response to COVID-19 disease. So this was the Chinese experience on 44,000 patients and their distribution. I've already sort of basically covered this. But this is the key case fatality rate, and this is where this issue with age seems to come up. People over 70, 8% mortality, rising to 16%, and this is what is the driver of decisions that must be just awful to make in places like Italy right now, where they're saying we don't have the capacity, the ICU and critical care capacity to manage this disease, so we're going to have to not provide the same care in certain hospitals to people based on age, and that's what happens when capacity is overwhelmed. But you can see the populations downstream in terms of age, especially the 50 and under population. They're not dying of it in the Chinese experience, but they're going to be big drivers of it. So this is going to be how we manage the mitigation strategies, and these people that are unlikely to die or even need hospitalization will be the key protective event that will keep our 60-plus population from overwhelming the health system. So one would think with respiratory viruses, especially with things like flu, that bone marrow transplant patients with chronic immunosuppressions would have a bigger signal. In the Chinese experience, they did not. And China, a place like Singapore or Hong Kong, does a lot of the same stuff we do: bone marrow transplant, solid organ transplant, high-grade immunosuppression for rheumatologic or other diseases. But what they really saw in terms of critical and severe disease was the influence of common chronic comorbidities like uncontrolled hypertension, uncontrolled diabetes, heart disease, and chronic obstructive pulmonary disease as drivers of severe disease in their experience. So the comorbidity associated with advanced age is really important to remember, and that is the population that, as we think about how to manage people presumptively or with confirmed COVID-19, as capacity starts to be challenged, how do we manage those populations and decide when they need to come into a monitored setting? How do we counsel people that are unlikely to have severe disease about the red flags? Right now, I just talked to Dan Melnicki, one of the ER docs who worked last night, and they only saw 16 patients in the emergency room at Frederick Hospital last night. And that he's never had anything like that. People are staying out of the hospital right now. But we need to figure out how to manage them, because people with heart failure are out there, people with bacteremias are out there. Right now, everybody's sort of scared to come in, but that will come at us very soon. I'm an HIV doc, as Dr. Lean said. I'm less concerned about the HIV part. I'm more concerned about the fact that half of our people with HIV are 50 and older. So how to keep the 50-year-old and the comorbid diseases that are non-HIV related. We've had some early experience with some of the cancer patients having this, and I'm not aware of any cancer patient yet being admitted, although we'll have to watch out closely for that. And then here's another small silver lining. Pregnancy, unlike with influenza, seems to be, COVID-19 disease seems to be well tolerated, and there's no evidence of prenatal transmission of this disease. So when it comes to the pathophysiology of what's happening when people get really sick, there's an observed, and these inflammatory markers are probably a signal for this cytokine IL-6 response that produces a cascade that ends up leading to ARDS and the other organ system dysfunction. So there's an observed surge of cytokines in patients who go on to develop the severe disease, and so that potentially is going to be a target and has been presumptively treated as a target for therapeutics, although much more to be defined on this. So this is the disease course. I think it's very important that when we're seeing things, that when we say the disease is likely to be mild, there will be young, otherwise healthy people that will pop up that end up having severe disease and then end up even progressing on to death. And I would point out at the bottom of this, there are ways that critical disease patients can be effectively cared for back to recovery. And we'll learn a lot in protocolizing this care about how to do that in the most effective evidence-based way possible. It's just, will we have the capacity to give them the kind of care that would give them the best outcomes moving forward? So I think one of the things we should all be most concerned about based on the experience with SARS-CoV-1 is the transmission dynamics in healthcare settings. And so I just wanted to go over a little bit about this. You're all keenly aware about respiratory secretions. The paper, which I'll give you a look at some of the data from the New England Journal last week about the modeling of transmission dynamics with both cough and with aerosolizing procedures and also on surfaces is very, very important. But the 6-foot rule, this is a droplet transmitted thing. Most people are practicing social distancing. We're not sitting in a room. That's because this is a very important part of it. But more and more in our healthcare environments, for people that aren't doing airway work like you are, it's going to be about fomites. So people touching surfaces where the virus has been and then subsequently touching their mouth and face. That will be the dominant driver in our healthcare settings, which, as I've mentioned, will be amplifiers or relative buffers, depending on how good a job we do in controlling nosocomial spread of this infection. So here's the data from that New England Journal paper. This model showed an aerosolizing procedure can keep COVID-19 or SARS-CoV-2 in the air for a couple of hours, and then showed differential rates of sustained live virus on surfaces. The surfaces to really be aware of are steel surfaces, and that can go on for days, as well as plastic. Cardboard and copper are less likely to have sustained transmittable virus on the surface. And it's very important, again, to know inoculum, right? That's where a emergent intubation in a relatively unprotected way in somebody who's got early SARS-CoV-2 disease. And remember, when they're really sick, they probably have higher viral loads, but they may have had higher viral loads earlier than they do at that point. There's going to be data coming out soon that show that people are sicker who have sustained higher viral loads later in the course of their illness. But that's where the control, doing it the safest way possible, is definitely the thing to do. So unfortunately, we had a brief period that we relatively squandered to do case finding and then classic public health responses where you quarantine and isolate and do contact tracing. The scope of the epidemic has passed us by as a city, as a state, and now we're into community mitigation. I would say as a health system, we really have to commit to doing the best we can with containment in our health settings. So contact tracing is ongoing for our healthcare workers and for patients who come in that aren't diagnosed and that subsequently get diagnosed. I think we're getting our processes improved, especially through the ED, about isolating people. We're really focusing in the ambulatory environment about symptom screening before people come in and working to get patients to do more and more stuff from a distance. I would say one thing we all have to get much better at is self-reporting of symptomatology and making our health-informed decisions about whether we come in or we don't come in. Again, I'll call out how lucky we are at Freighter to have this fantastic microbiology lab. Many of the hospitals in our area do not have the same capability to do testing for their healthcare workers that we do. Yesterday, we did over 100-some tests on our own healthcare workers, which is an enormous gift, both to them personally and to us as a system, to be able to have that testing capability, which I am certain they don't have at Ascension or Advocate Aurora. So you've all heard this bend the curve concept, flatten the curve concept, and this is what it's visually represented as. And the bottom line both has a decreased number of cases, but it also allows us to maintain some measure of capacity to give people the kind of care they need. And the point of this is just if we can do these mitigation strategies, you break a cycle of transmission, and that improves the overall health of the community. And we're doing a good social distancing thing. It's a little awkward to be talking on the phone instead of talking in person, but these social distancing things will work. And here's some historical evidence of this. This is during the influenza epidemic of 1918-1919. The city of Philadelphia went ahead with its annual parade, St. Patrick's Day parade, and the city of St. Louis did not. And this is what their epidemiologic curves associated with influenza at the time showed. So there's historical precedent, and I would show you this data, which is sourced accordingly up there. It came from my wife's Twitter feed, but and it does have public health data attached to it. And I just actually asked the state if they could start giving us this. This is the experience of Tennessee and Kentucky, and about their social distancing and community-based mitigation strategies. Tennessee has been very late to the game, although they've been testing at a comparable rate to Kentucky. And you can see their rate of rise is dramatically different than Kentucky, which was an early adopter of community mitigation strategies. So controlled for relatively similar numbers of tests, the number of new cases is much slower in rise. And I'll give you anecdote. Our testing center that I manage over at Sargent, the positivity rate has been relatively flat in that. In the last week or so. So I am hopeful, and this is the reason I asked the state today, if they could give us data like this to show us our rate of rise so that we can understand with more detail what's happening in Wisconsin. So I'm just going to give the generic comments about personal things that you can do. One is really take good care of yourself. Many of you probably been working much more than normal, and at a time when your family and friends are nervous about what's going on, understandably. But it's really important that you take care of yourself, and that we do everything we can to follow infection control guidance, and I'm sure we'll talk about that more. Household spread is going to be a driver, so it's very important, whether with patients or with ourselves, if we become sick, that we try and prevent spread within the environments that we habitate. Right now, when we're all working, that's work, but also at home, practicing social isolation with respiratory tract symptoms, if we can help that in our home environment, and thinking about that. There's nothing magical about Purell. Good hand hygiene with soap is just as effective. And then, I'm not going to comment on handmade masks, but one of the things about handmade masks, which I'm not sure what the significance of that is it does serve as a reminder not to touch your eyes, nose, and mouth with unwashed hands, and again, staying home and sick. So all I will say as a general statement about anesthesia and CRNAs as it relates to PPE is, as I've said before, you're at the point of the spear. I completely understand why this is a dominant consideration for you, and I would tell you from the outside of your department, your leadership has been an active voice in advocating for optimizing access to PPE. And as I've already kind of alluded to, I think it's absolutely essential that whether you're in the OR or you're responding to somebody with acute respiratory decompensation, that we do this in the safest and most controlled way possible. And that's where communication between a critical care team, I don't know if you guys intubate all the people in the MICU or not, but communication and getting people to understand that once you get to 6 or 7 or 8 or 10 liters of nasal cannula, it's probably best to do something before it's a collapse situation, because the risks is going to be about the number of times you're in the person's airway, and doing it in the safest way possible is going to be really important. And then I think you as a group can be really helpful to us is understand how, I'm sure this is an intense subject of investigation among anesthesiologists right now. How do we get data that we can all use to evaluate the risk of various procedures in nosocomial settings? I worry about you guys. I worry about nurses, most probably. I worry about critical care docs. I worry about respiratory therapists, and then I worry about the hospitals, the people that are going to be engaging with people that probably have it but haven't been diagnosed with it. That would be my risk. And I say to my ambulatory group, we all would agree, and they universally back me up on this, that if we have limitations in PPE, it goes to you guys first. and we stand ready to help in any way we can to keep you guys safe. So these are some general recommendations about the coronavirus that I actually like from WHO, and it does really recommend following kind of structured lines of communication, avoiding rumor spreading, and being kind of fact-based academic doctors right now. And I sometimes fall victim to that. There was a report that that sounded intuitively positive, like if you hold your breath for 10 seconds, you probably don't have coronavirus. And I tried to find out where that came from. It sounded like a good negative predictor, but there's really no evidence of that, and it ended up being something I sort of got transmitted socially. And so I'm constantly reminding myself, like, hey, yesterday I was asked to stop, to tell all the primary care doctors not to send people for nebs to the ED. And I was like, well, what's the data behind that? And getting into that space, and it turns out there is data behind it. So we should be data informed as we make these decisions. And then empathy is important. I guarantee you somebody that we know and care about in our departments, in our hospital, will end up getting infected with SARS-CoV-2. How do we respond to them empathetically, not pointing fingers, not blaming, while at the same time, responding with evidence-based ways. I think this idea about learning about the disease, I'm really grateful for the opportunity to provide some of this information. I think every single department in this place should be getting basic COVID-19 education, including all the staff, and we're behind in that regard. So just a couple lines on treatment. The treatment is what happens whenever there's a new infection is you pull everything off the shelf and throw it out and see if you can get some, lab-based data that says that there's antiviral activity, and that's what we've done. So we took some of my old HIV medications, which historically were looked at for SARS-CoV-1, and tried that, negative studies. You've heard about chloroquine and hydroxychloroquine, which appears to have some impact on viral dynamics. The significance of that is uncertain, and it certainly has some potential toxicity. You've heard about whether ARBs should or shouldn't be stopped. The American College of Cardiology has said, keep going if you're on it, don't start it if you're not. Remdesivir is definitely an antiviral that has activity, but Gilead, the company that makes it, has just said we're not going to give it to anybody outside of clinical trials now. And there's tocilizumab, which is an IL-6 inhibitor, is thought to be a potential therapeutic for that interleukin-based storm that occurs, although it's not clear whether by the time that happens, the horse is out of the barn and the impact of that biologic would be indicated. So I'll close with a couple comments on vaccinology. The sequence of this virus dropped on January 10th, and within a week, labs around the country had compounds that they were experimenting with to see if they could develop a vaccine. The vaccinology of this is going to be complicated because, as I've said, there is an immune activation component of this that produces severe disease, so understanding whether a vaccine protects or potentiates that negative thing will be very difficult. But this is going to be the number one scientific endeavor in the next 2 or 3 years to find effective vaccines. And I'll just show you this last slide, which shows the pace of vaccine development since SARS first showed up in 2002 down to the current now. There likely will be this month candidate vaccines in the field for SARS-CoV-2 coming up. Whether those will prove to be effective and whether and how they would be scaled up, when Anthony Fauci says 12 to 18 months, that's probably on the conservative side. That's our very realistic estimate. It could certainly be longer. As I mentioned before, people have been trying to develop pan-coronavirus vaccines for a long time and so far have been ineffective. So these are some sources. I just found one of these new that you guys, some of you that do critical care will probably find useful, that there are more of these sites popping up, but the Brigham has a protocol aggregator site that they're standing up. And then I know CDC has sort of taken it in the teeth on this epidemic, but they are really the world's experts in public health, and if given the opportunity, I think can lead us very effectively. And I've been very impressed with our state health department. I've worked directly with them for the last several weeks. on a committee that they've formed, and I've been very impressed by the quality of that group as well. And then I would say that MCW Library resource that's on here has an aggregated site for a lot of information that you can use in research as well. So I will stop there and open it up for questions.
Cindy, I was wondering, ability of routine patients who are asymptomatic having or their will, if they are infected.
I'm having a hard time hearing you, Dr. Lean.
If you're not speaking, can you please mute your phone? I was wondering if you could comment on the use of routine for patients who are having nasal surgery, sinus,
Yeah, it's a really good question. The otolaryngologists, especially rhinologists, are being observed, and I cannot point to evidence. I'm going to try and practice what I preach, but you know that there is a tropism for the nasal mucosa for this. So skull-based and rhinologists in particular probably are going to prove to be a population that is at higher risk for exposure associated with their work. And I think this is where and this is exactly the same thing with PPE. If you look at a resource-constrained but vital part of our response, so testing is like PPE. And we can do about 400 tests a day in our lab right now, and we have to make decisions about which of those 400 should be there. Should we do low-risk, low-symptom screening for ambulatory patients, or should we do, pre-op screening for somebody who's going to do pituitary surgery or going to do a needed, non-elective nasal surgery? And there's a group that's coming together around some of these questions. I think you're going to see in the next week or two a lot more expanded capacity to do testing at our lab. And in that setting, I think the resources will be freed up more to do some of that screening. I would tell all of you that in your pre-op holding areas to please pay attention to symptom screening, fever, cough, new or worsening cough, shortness of breath, and be mindful of that, because as I said, you could have called 2 days ago and checked in on somebody, and they could have been in that asymptomatic phase, and then as they're presenting for surgery, they could be screened. And those populations, we can and should probably get tested. Whether we get to the point where we say everybody with anything above the diaphragm before they get operated on gets a screen, not a symptom screen, and some testing screen a day or two before, it will not eliminate completely the risk, because you could do a screen, the nasopharyngeal screening a day before a surgery is not going to capture all the patients who end up developing COVID-19. It'll just reduce the burden of them significantly. So that's something that I know Mike Stadler has been actively advocating for, and I think we will develop more and more lists like that of people, whether we do, for an emergent upper GI procedure that somebody's having a variceal bleed. That's a bad example because they're going to have to go ahead and do it. But something that could be deferred for a short period of time is the kind of use case we're talking about. So, excellent question. Something that I know that people that are in the OR space and people like Mike are actively considering.
Are there other questions?
Yes, this is David Q. I have a question. My question would be about the aerosolization of the virus. And if it's aerosolized in a room that we're doing an intubation, how long with the aerosolization do you anticipate it being in the room? How long to people have to have their N95 masks on after the patient has been intubated?
So that if you want to extrapolate from that model, that the virus can be aerosolized in that model for 2 to 3 hours. So, and I'm not the one that decides this. It's an infection control question. But if I, as an infectious disease doctor, looking at that data, would say that it can be potentially aerosolized for up to 2 to 3 hours. So the N95 mask, if I were advising on it, I would take that data in consideration. I'm being a little cagey about an answer because I'm not the one that decides this. I'm the ambulatory guy and an infectious disease doctor, but that's how I would interpret that data.
This is Kathy Lauer. I'm not sure if this is a fair question for you, but I'm wondering what your understanding is of reusing PPE, refreshing N95s, and just if you could comment on that.
I'm not an expert in it, but I will venture an answer. We all don't have all that we need in testing, in PPE, in ventilators likely, in nurses and hospital staff eventually. And so in that setting, I think we have to understand relative risk and use evidence to make decisions about how to maximize the resource. So I've talked to you about how I think you deserve a mask more than I do as an infectious disease doctor. In this setting, if our choice is a UV-treated N95 mask that gets used that is not grossly contaminated by blood or respiratory secretions, and there is evidence yet to be proven in a controlled trial that putting that in a medical grade UV light treatment system can reasonably be assumed to reduce the risk of that being contaminated, then I think we should look into that. And I would rather you have a new mask and you give me that old mask, but there's other infection control things associated with it. So I think it's until the supply chain can get us what we need, I think we should be looking at, most importantly, at not wasting PPE in environments where we don't need it, making sure that it's where we need it, not in my ambulatory clinics, but it's in your ORs, and that we then aggressively work to understand how we can get it from whatever source, whether it be a donation or a new supply chain source. But if we can't assure that based on risk decisions we've made transparently, because I think transparently is really important, that we then explore ways that aren't quite yet proven, with some trepidation and some commitment to proving that they ended up working, whether it's through the evidence or through our own studies. That would be what I would say.
If there are no more questions, Dr. Fangman, I'd like to thank you very, very much for this presentation and for sharing your time with us this morning. Very, very helpful.
Yep. And thank you guys. You guys are my heroes right now. So thank you for all you're doing, and stay safe and take good care of yourselves and take good care of your families. John? Yeah.